Thank you very much, Ramona. As you'll see on my first slide, I've got no conflicts of interest to disclose, though perhaps the glass of Prosecco last night might have helped in terms of what Ramona's just said. And I would also particularly like to thank Alex for the invitation on behalf of ESHG. And when I replied in the email, when I opened the email, it didn't occur to me, because it said ELPAG award, it didn't occur to me that it was going to be awarded to me. And you know, unsurprisingly, well, I'm here, so I said yes. I said, and I still feel very honoured about it. And I was obviously delighted to be offered it. What I didn't say, because it perhaps might have not sounded so professional, and I don't know how well it translates into other languages, but I was completely gobsmacked. So I'm very rarely lost for words, but that was one of the occasions, so it was a huge and unexpected honour. So what I thought I'd talk today, because I've worked in genetics a long time, is that you might be interested to know some things that I've learnt from working in the field. So think about colleagues in genetics and other disciplines. Obviously that's other genetic counsellors, clinical geneticists, clinical scientists and other laboratory colleagues in metabolic, particularly in our centre in Manchester. As Ramona said, I worked in cancer genetics for a long time, so surgeons, oncologists, clinical nurse specialists, but also, I guess, when Ramona talks about my other interests, so including ethicists that I've worked with, psychologists, and also my counselling supervisors, students and trainees, particularly genetic counsellors, but also clinical genetics and training, and more recently, which is I've really enjoyed, genomic and cancer genomic trainees. But probably most of what I've learned has been from the patients and families that I've seen over the years. So I think some of this will be unsurprising, even if you're relatively new to the field. But one thing I found is, well, I've learned most from listening to other people's expertise and perspectives, but also when I felt listened to by others, I think. And developing and maintaining relationships in multidisciplinary teams is really key. We can't deliver good enough, or let alone high standard clinical services, or achieve academic advances without that. Being patient focused includes giving advice and making recommendations. So I think for genetic counsellors, well, for everybody, it's really important that we remember that non-directiveness isn't always the most appropriate approach. I'll kind of come back to that later. But I think we also need to bear in mind that it's really important we don't have, I suppose, higher expectations of patients and families than we might see in our own lives and in our own families. And the other thing, which, in terms of about colleagues, this really was from my most recent counselling supervisor, because often when we have discussions about what's been interesting, challenging, I certainly said, and other people I've been in supervision said, well, it's really hard because I didn't really like them very much, which you're not really supposed to, not meant to feel, you're probably not supposed to say out loud, or you feel you shouldn't say out loud. And he would say, well, that doesn't matter. When he says it doesn't matter, that sounds a bit too blunt. That's not the point. It isn't about liking people, and actually when you like people, if we're working with them clinically, that can actually cause some problems. And that not all patients, and for that matter not all colleagues, are a joy to work with, but they don't need to be. And recognising that there perhaps is a dislike or a struggle, and I think more importantly what's triggered a negative reaction, means it's still possible to work effectively together. And thinking about students and trainees, one of the things I think for those of us who are more experienced or in more senior positions, it's really important to remember, we were students and trainees once. I can still remember how nervous I felt drawing a family tree for the first time in a real clinical setting with somebody there. And I still feel, oh, mitochondrial inheritance, I'll have to go and look that up again before I try and explain it to somebody. And so I think it's really important that we have that kind of reality check and have realistic expectations of students and trainees. And I think one of the really important things is that they can and they should, and hopefully they do, challenge the usual way of doing things. Obviously there's a way to do that. That means it's perhaps more easy to engage with what's being suggested. And also, and we've seen it at this conference, they can prod us to, by highlighting important and less recognised issues, as, for example, happened with the educational session yesterday morning. In terms of what I've learnt from patients and families, so whether they are the patients, children, young people or adults, they can adapt and they can develop resilience. But what they often need, like the rest of us, is they need time and support to do so. Anyone who's been in clinic with me is somewhere between surprised and shocked about how little I talk about genetics, I suspect. But I certainly feel that people rarely, if ever, come to clinics, to our clinics for a lesson in molecular biology. I'm fascinated by it, but I can accept perhaps they're not. And getting the gist of it, getting the essential bits of information, the bits that help you understand what's being talked about is enough. And what's much more important is addressing their questions and concerns. Now, I did love it the first time I talked about transgenerational epigenetic inheritance, because it's the first time I'd done it, and I was so pleased I'd been able to understand it. And then I also realised this is really not helpful. It's not really making much sense. And of course, you know, if I was trying to do it again, it would make very little sense to me. I think we're increasingly, I think as humans we can recognise this, as professionals we don't always recognise it. Patients, families, of course, they're expert in their own lives and in living with their rare condition. So that's also known as lived experience, which sometimes people have a bit of a kind of antibody reaction to that kind of term. But what it's about really is the knowledge, understanding that you have living in a certain situation with, for example, a certain rare condition, which other people who've only heard of such experiences absolutely do not have. And another thing, and again, it's surprising that it can be surprising when I first thought about it, but patient-reported outcomes are really important to provide patients' perspectives on the benefits and harms of interventions. And these are beyond the things that we often think of as outcomes. So obviously, survival's often an outcome we're hoping for, avoiding major and morbid events and, for example, biomarkers. But the patient-reported outcomes are often the most important outcomes to those patients and families, rather than what we think of traditionally, for example, in clinical trials. So one of the things that I've learnt more about more recently is it's better to think about difficult conversations rather than about difficult people. So thinking about the discussion as being difficult rather than labelling the other person, be they a colleague, a patient or a student, as difficult. And sometimes, you know, taking a breath and remembering, we tend to be quite gentle about the way we judge ourselves, at least in terms of our intentions, but we tend to judge what other people have done or their intentions by the effects of their actions on us. And it can take a bit of a leap of faith sometimes, but even when we disagree or our positions conflict, we can have shared interests. So by positions, I mean what our behaviour is, what we're saying and what we're doing, and our interests are what we're trying to achieve by adopting our positions. So those of you who have seen patients in clinic will have come across similar sorts of things being said by patients and families. So, you know, we don't want you to tell our children that they're having a genetic test. I don't need counselling or lots of appointments with a surgeon. I just need to have my breasts removed. And it's quite interesting to stop and think, what's my first response when I hear that? My first response is, well, clearly they don't understand. Clearly I've not yet given enough information. It might be, you know, I might make assumptions this is an anxious patient. There's all sorts of things that do, and certainly I could imagine myself slipping into, I'll just give a bit more information, then it'll all suddenly become clear. But what we can all tend to do is then avoid kind of naming the issue that's there, and perhaps, you know, or even shutting down difficult conversations. So you can imagine nodding and then moving on to the next thing that I think I've got to talk to in the consultation. But it's very striking, because, and I've found this strange, I'm a trained medical mediator, is how much difference it makes. Because we all think we listen. What we don't always do is show that we've heard what someone has said. So something as simple, I'm not sure simple is quite the right word, but in response to the first person, okay, so you don't want us to tell your children that they're having a genetic test. And it can feel very strange, almost repeating back what somebody said. But it's very powerful at showing somebody you actually have heard of it. It's not saying you agree with it, but at least you've heard it. And it does maximise the chance that you can get to the point of that you share interests. In this case, it might be what are the best interests of the child and protecting them from harm and so on. So one of the key things to think about is exploring before explaining. So, okay, so what you said is you don't want us to tell your children that they're having a genetic test. It'd be really helpful if you could tell me a bit more about it. And then there might be all sorts of things that come up. It might be the traumatic experience that they had when they were told about the family history. It might be that there's been a recent important major bereavement in the family. There's all sorts of things, and it can help you shift things. You may still end up not entirely agreeing, but at least you'll have a better understanding of each other. And this is the sort of thing that happens when we can't identify shared interests. So you'll remember how virologists were both the sung and unsung heroes during the pandemic. And there's a really interesting podcast you can listen through through the BBC, and you can listen to it outside the UK. And the bit on it's about the toxic debate over lab leak theory hampering the search for COVID origins. Now, obviously I'm interested in what the actual origins of COVID were, but that's not the main issue here. But when he was doing this podcast, John Sudworth, he described how he's heard virologists question the motives and professionalism of colleagues with whom they disagree over two alternative possibilities, and how professional relationships have been damaged and friendships lost. Now, obviously, it's not always easy to identify shared interests. This is not by any means the most controversial thing from my perspective that Suella Braverman has said, but I think it's fascinating. In fact, it made me laugh. The Guardian reads, so The Guardian is a centre-left newspaper in the UK, tofu-eating wokarati. I mean, why she appears to have an issue of people eating tofu, I don't know. I mean, I don't like it myself. But I think it's really problematic when words like woke are weaponised and really turned into an insult. So what I want to do is finish by thanking and acknowledging two people who have been particularly important in my professional life. Margot Brazier is one of the UK's leading healthcare lawyers, and she was my PhD supervisor and was kind and generous beyond words. And then Lauren Curzon-Storer, who many people here will have known. Lauren sadly died last November. And she was a genetic counsellor in Manchester and set up the first MSc programme and really drove the development of genetic counselling profession in the UK and Europe. And like me, was very attached to ESHG and everything that it stands for. Thank you.